It's a personal story that I'm going to share with you. So in February, we concluded a conference, Indian Association of Palliative Care. The theme was Metamorphosis, the emergence of subspecialty palliative medicine. We had specialists from all specialties in medicine like oncology, nephrology, neurology, pulmonology, cardiology, ICU and palliative care coming, deliberating on how we can integrate palliative care with each specialty. Cut to March. 80 kilometers away is the city of Mysore. I had my uncle with end-stage COPD dying in an ICU. I knew all that needed to be done to manage him, including giving him morphine to ease his breathlessness. He was struggling to breathe, and I'm requesting the critical care physician in the hospital to please give him morphine. His daughter, me, we were asking. We know he's 90 years, he's got a very bad lung, we know he's going to die, but at least let us lessen his suffering. So let's give him little morphine for his symptom. He refused to give morphine. And I thought, here I am training hundreds of doctors in palliative care, but yet not able to help my own uncle, whom I consider to be my father. So what I wanted to tell was the inequity is very clear, right? It's only some places it's very well developed, palliative care. Some places it has not reached at all. There are a lot of doctors out there who still need to be educated about what palliative care is and end-of-life care is. And 3, it's about that misconceptions about morphine use, that opiophobia, what we call, which needs to be addressed. At the ground level, difference still exists. Just about 2 cities, neighboring sister cities, it's just 1.5 hours journey to reach Mysore from Bangalore, but still it exists.
We have already treated her pain. We should convert on oral morphine and other medication. There will be a uniformity in teaching, there will be a uniformity in training, and this will make a life easy because, for example, if I am seeing one patient today and I want to send it to interior part of Jammu and Kashmir or Bihar, so the doctors and nurses should be trained in the uniformity that this is the way we should treat and approach a patient with intractable pain. This is the way we should approach a patient with intractable dyspnea. So this is what we are trying to bring everyone together.
There should be a growth now in next 6 months.
With whatever way, but you have to grow.
I feel that palliative medicine, to grow and sustain in any country, it should be a specialty. So to be a specialty, it should have its own specialist training and a specialist training pathway and the specialist training process. And MD program provides that specialist training pathway and process, which should help those people who take up the MD program to stand shoulder to shoulder with any other specialist. So ours is a very competency based training, that we want them to be very competent doctor. We want them to be compassionate, we want them to have empathy, but at the same time they should have impeccable clinical skills and knowledge, and they should be comparable with any other specialist. And it can be only achieved by this structured training program, which is for 3 years duration, to make them specialists. So that's why it's very important to have that MD program.
AIIMS Delhi has started post-graduation program, and now we have a lot of 27 almost postgraduate. We have taken over the ward in charge of 40 bedded ward. We have 46 bed. We have 25 more beds in palliative intervention. So a patient who is requiring some kind of intervention will be admitted over there. In the departmental itself, there is good interdepartmental seminars. We discuss cases, we discuss a lot of journals, new articles. Gangaram hospital development is happening fantastic. They are working very hard to develop this, and they have appointed one of our first MD palliative medicine student over there as a consultant, and they are working very nicely and very systematically. And the advantage of having palliative medicine in Gangaram is that Gangaram is a private corporate hospital. And this is the biggest learning, that choosing a right person is very important, and that is what we are doing.
Our hospital was inaugurated in 1952, so it's more than 75 years, and we have been practicing oncology care, and other care of the life-limiting diseases that the patients are admitted with by clinicians. We as physicians, as anesthesiologists and pain physicians, also look after them, but the term palliative care was not started or had not really taken birth in our hospital till about 2017, when a few clinicians realized that these services are important to be started as a specialty service in the hospital. We've done it so well, we have worked so, we've come so forward. Palliative medicine department was started just last year in 2021 to be exact. We have a consultant who is a postgraduate from a very premier institute of India, that is All India Institute. He's already got his master's, his postgraduate degree in palliative medicine. We are the multi-speciality team, but he is completely a postgraduate in palliative medicine. So now we have 2 students. So yes, we are progressing, though we have many miles to go.
Ours is a multi-speciality hospital and we have several departments. In fact, ours is the largest, providing training to postgraduates from different specialties. Because overall, once, a patient comes to a doctor, the basic services, that is the services of a general palliative physician, that is talk to the patient, talk to the family members. That care is provided by the primary physicians. But now when the palliative medicine has grown as a specialty, they feel that the need to, include the palliative physicians in their team. And I think it is most appreciated by the oncologists who are giving medical treatment to the patients who are suffering from cancer. Most of the people feel there are, some myths about understanding palliative care. People feel that only the cancer patients they needed palliative care. And also people feel that palliative care is needed by the patients who are dying or when they are terminally ill. So actually it is an umbrella. The palliative care should start as early as possible.
2 sides of the coin. You cannot morally depress the patient, but when the patient is fine, in the good process, you can maintain the decorum that death is the inevitable part, but you have to manage death in a process where you have to morally build every patient and their family.
The principal work through Lien Collaborative was the CTC program, which we initiated from 2016 onwards. So when the 2016 work started, what we tried to do is to bring palliative care right in the hospital where the action was happening. And this facilitated a lot of palliative care departments forming within the hospital. This led to creation of new training centers. It also led to starting postgraduate training program in the form of MDs and DNBs across India. So I think it was a transformative role in terms of a growth that was plateaued or stagnated. There was a frog leaping or an accelerated growth post Lien Collaborative CTC intervention. So I think that's a very important societal impact that it has created.
Now she's almost ready to go. We need to have multiple things at home, to explain her. The sugars need to be well controlled.
I feel that once we have a significant number of palliative care specialists here, they should probably create that drive to make this as a specialty and grow. I always tell in a very cynical manner that it shouldn't be a hobby or it shouldn't be a second job that what you're doing. If we want to propagate palliative care, those who are taken up palliative care should do it as a primary job and move it forward.
And you can say, it will help a lot of patients, a lot of people, it will do a lot of good, it will reduce suffering, it will improve people's quality of life. These are catchphrases which administrators like.
The pedagogy is a lot focused on teaching, discussion, role play, and even bedside teaching. There is a need to customize because different countries, they have a different palliative care service setting. So some countries have only at hospital level. Some countries hardly have any palliative care service. So we need to customize so that we can meet their needs, and the different healthcare worker competency can also be educated differently.
Done for the day. Smile. Thank you.
The Lien Collaborative program is sort of mature now, and we're looking to really provide it with good governance structure. It's actually making sure that in any countries that we've gone in and developed a program, that it's sustainable, that the development will continue. And that development might be in curriculum development, in the development of palliative care nursing and medical programs, postgraduate education, etc. So it can really grow and enrich within the country and across the Asia Pacific region.